Thank you, Stephanie. And I'm particularly grateful to CIHR and INMD for sponsoring my travel to this meeting. And Mary Jo, you've been extraordinarily helpful. Thank you. And it's also a great pleasure to come back to Canada because I was a member of the CIHR INMD almost 10 years ago for 3 years. So I learned a lot about Canada and admire terrifically the work that's going on here. Today my talk is going to be more U.S.-centric, and I apologize in advance for that, but I think that the lessons that we're learning and the trends that we're seeing may help inform the strategies that you are thinking about and need to come into place. This is also going to be a talk that focuses more on the public health approaches to this problem than to the clinical approaches, although I'll spend a few minutes about talking about the challenges that are presented by the clinical issues associated with obesity. So I want to begin by sharing with you where we are with respect to the prevalence of obesity in the United States and move from that into what I think are unique opportunities and potential solutions and focus on what I think are the best investments with respect to obesity prevention and control. So you see here the changes in the prevalence of obesity in U.S. men. These are data from the National Health and Nutrition Examination Survey, which is now done on a 2-year basis. And you can see that there has been a continued gradual increase in the prevalence of obesity in men, in contrast to what we're seeing in U.S. women, where in all 3 major ethnic groups, non-Hispanic whites, non-Hispanic blacks, and Mexican Americans, we now have a plateau. Even though it looks like there's an uptick in non-Hispanic blacks, that is not a statistically significant uptick. But one of the concerns is that despite the plateau that we're seeing, there is still an increase in the prevalence of severe obesity, defined here as a BMI greater than or equal to 40. 8% of women, 4% of men have a BMI of 40 or greater. And so what this says about the trends in obesity is that even though there's a plateau in the prevalence of obesity, the severity of obesity is getting worse. That is, the tail of the distribution is continuing to increase. We're seeing also positive trends in children and adolescents. These are data from the Pediatric Nutrition Surveillance System, which is a very large surveillance system that my division conducted at CDC on an annual basis. And this targets about 2 million lower-income children, a particularly vulnerable group. And you can see from this slide that the only increases that are occurring among 2 to 5-year-olds is in the the American Indian Alaskan Native population, similar to your Aboriginal population here. We're seeing also a similar pattern in the distribution of obesity in both children, in younger children and adolescents. So these are data that show U.S. youth, both boys and girls, over the last 12 years. Again, girls, like women, are flat, but the prevalence in boys is continuing to increase. And what's particularly concerning about this trend is that if you eliminate the trends in African American boys from this analysis, boys are flat. So the disparities with respect to obesity in the United States are what are driving the increase among boys. We don't know exactly what accounts for the increases among men in the United States, but we do know that this is a significant issue among boys and particularly among African American boys. Now, the other positive trend that we're seeing is that this shows 5 states or communities, and there are an additional 3 or 4 that we now have declines in the prevalence of obesity. The measures are a little roughshod, but the trends are comparable. What is a concern here, though, is that in those places where we're seeing a decline in the prevalence of obesity, the disparities are actually widening, because the trends that we're seeing are declines in the prevalence of obesity in the non-Hispanic white population, but not the African American or Mexican American population, with one exception here. But so the disparities are actually widening as the prevalence of obesity decreases. Now, it's worth asking what accounts for this plateau in prevalence. And it's worthwhile looking at what happened to the consumption of the per capita consumption of tobacco beginning in 1900. And you can see from this slide that there's a relatively linear increase beginning in 1900 and continuing up until 1954, when the first reports linking tobacco and cancer appeared. Tobacco consumption peaked in 1964 at the time of the first Surgeon General's report in the United States and stayed pretty flat until a variety of policy and environmental initiatives began to kick in and the decline in tobacco consumption began. Now, there are a couple of important takeaways from this slide. The first is that that plateau in per capita cigarette consumption began, I think, with an awareness of the adverse effects of tobacco. And I think that's where we are with respect to obesity, that there's the publicity that has accompanied the obesity epidemic has changed behaviors in ways that we can't precisely measure, but I think account for the plateau. The second is that the decline in tobacco consumption was not a consequence of federal initiatives, but a consequence of local and state-based strategies. And that's what we're beginning to see now in the United States, an increased focus on those local and state-based initiatives. And the third takeaway is that there wasn't a single intervention around tobacco that accounted for these declines. It was a multiplicity of policy initiatives. And the important word there is policy, which changed access to tobacco for minors, which began to change the social norms around tobacco. And I think for us, that's one of the challenges that remains, and we'll come back to that. Now, the issue of obesity begs the question of what are the public health strategies on which we should focus. And it's worth going back to this paper particularly, which I think is a very instructive paper about what kind of food targets we ought to be using around obesity. These are data from the Nurses' Health Study and the Health Professionals Study, long-term follow-up studies that have been done by the Harvard School of Public Health. And you can see here that foods like unprocessed meats, processed meats, sugar drinks, French fries, potato chips, refined grains, over this 12 to 20-year period were all associated with weight increases, whereas increased consumption of whole grains, vegetables, and fruits were associated with a decrease in body weight. And that, I think, helps us focus what the nutritional targets of this ought to be. We don't have quite the same data over changes in physical activity, but we know that physical activity has declined over the same time period, largely a consequence, I think, of changes in community infrastructure, the widespread development of suburbs that lack access to parks and recreation facilities and made impossible, at least in the United States, for people to walk from where they live to school, to business, to shopping areas. The other important observation, in my view, is the data that were included in this paper by Claire Wang last year, which looked at the caloric deficit necessary to achieve the U.S. Healthy People 2010 goals, which was a prevalence of 5%. And these are the daily deficits in calories required to get the mean body mass index back to 5% in the next 7 years. Notice how small that deficit is among 2 to 5-year-olds, 30 calories a day, 150 calories a day in the 6 to 11-year-olds, among 12 to 19-year-olds, it's 177 calories per day. These are achievable deficits that could be addressed by eliminating sugar drinks, for example, which account for 240 calories a day in the diets of 2 to 19-year-olds in the United States, or switches from a sugar breakfast cereal to an unsugared breakfast cereal, increases in physical activity through physical education programs. And these are the targets that we initiated at CDC beginning of almost, 15 years ago. The only target here which I think responds to a purely clinical approach are the risk factors that occur during pregnancy for early childhood obesity. Pre-pregnant weight gain during pregnancy, diabetes, and smoking during pregnancy all increase the likelihood of early childhood obesity. And I don't know of any good public health approach that's going to capture these types of risk factors. The remainder of these strategies are pretty straightforward. Energy intake, and you see here the strategies, the target of sugar drinks. I've listed here television time because television time seems to have its impact on obesity through food marketing directed at children. And I think we need to reframe that because it's not television so much as the advertisements on television. And when you talk to parents about changing television time, they're very resistant and reluctant to do so because television plays such an important role in allowing parents to accomplish their work. I really think we need to redefine this as advertising time, and we need some very good qualitative research to understand just how to market that to parents and what types of themes resonate with parents. Because the advertising by food companies has become pervasive and almost predatory. That there are ways that these food companies access children through social media and viral marketing, digital marketing, that accompanies children everywhere they go. And late last year, the Federal Communications Commission ended up attacking some of these food companies based on invasion of privacy because they were downloading not only children's addresses but the entire contact list on their children's phones and using that as a strategy to continue to market. Physical activity is a critical element here because, as many of you know, physical activity reduces obesity-associated comorbidities, has a major impact on elevated blood pressure, glucose intolerance, and hyperlipidemia. Now, that leads us to think about what are the best investments. Well, clearly in the United States, we need to continue to focus on disparities, that the body image of African American populations is quite different than it is among white women. Those disparities aren't always driven by poverty. The only relationship we see with poverty in the United States is among white women. There's no socioeconomic gradient associated with obesity in Mexican American or African American populations. But perception of body weight is quite different in the African American population, and I don't think we've yet established an effective way to address that. Clearly, it needs to be based on the health consequences of obesity in this group, and clearly this needs to be delivered by individuals in the African American community as opposed to an externally driven intervention. We need to continue to focus on evidence, and I think that we're at a place where we can begin to move from what to do to how to do it. Those strategies of those target behaviors that I showed you, I think, are what to do. How to do it, how we couch those interventions is what the challenge is today. And in order to do that, I think we have to rethink how we do and implement community interventions. So I think we've not done a great job, with some clear exceptions, in terms of linking stakeholders or working with stakeholders in this area to help them understand the evidence behind these interventions, which would lead to the development of a community-based intervention program or policy. That requires, as this slide shows, a participatory implementation process that, with respect to obesity and particularly around community interventions directed at policy or environmental change, this externally imposed type of strategy is unlikely to be successful. In addition, within communities, we need to have practical measures of progress. That means we need to begin to assess policy change in a much more direct fashion. And nationally, I think, and this applies to Canada as well as the United States, we need to have measures of policy implementation across communities so we can begin to assess how we're doing with respect to the policies of choice that we think are going to have an impact on obesity. And to do that, these are, I think, some of the important strategies we need to use. Like tobacco, this is going to require a multi-component and multi-sectoral intervention with setting specific focus around specific objectives, those target behaviors that I showed you earlier. We also, I don't know that we've done a good job of creating public awareness of the risks and benefits. We talk about obesity all the time. We're in this room. You all are very intimately familiar with the consequences of obesity, but I'm not sure the public is. And part of that, I think, has to do with our use of the term obesity, which I think is a pejorative term, almost with everyone who speaks English. And because it's a pejorative term, people think that obesity is that person over there who is 50 to 100 pounds overweight. Not me. I mean, I may be 30 pounds overweight, but I'm not obese. And as long as we continue to use that term, I think we're not going to have the kind of grassroots understanding and investment that we need to move forward. We also need to spend more time on the co-benefits of obesity prevention and control. Because we talk about obesity, we are not necessarily engaging the types of stakeholders we need to engage. And if you just think about the constituencies that are, for example, supporting fruit and vegetable intake, they're quite distinct from the constituency that supports breastfeeding. We know that, and in our views, those are linked under this heading of obesity, but they're not. They are not in the same coalition, and we need to think about what the co-benefits are of promoting farmers markets or community gardens. Those have values beyond obesity prevention and control. In addition, as we think about community-level interventions, I don't think we think often enough about the dose of those interventions. And dose is a product of the reach and strength of an intervention. So we often think about, well, if clinical interventions might have the greatest strength, but the most limited reach. And in the United States, particularly in the community programs that are underway, we need to be more thoughtful about selecting targets that allow us to deliver a very heavy dose of those interventions. Now, coming back to best investments, I think one of the most significant things we accomplished at CDC was to focus on procurement policies. So we developed a procurement policy, which is now called a food and sustainability policy at the CDC, which had some of the following targets. The elimination of trans fat, reductions in saturated fat and sodium, no added sweeteners to fruits, raw and prepared vegetables, less fried food. You can see those strategies here, low protein entrees. And these, we instituted this in our contract at the CDC with our food provider and then introduced it at the Health and Human Services Department. And they were able to evaluate the impact of this policy, and it turned out that more people used the cafeteria at HHS in Washington, and they've actually made a profit on these products. This has now been picked up by the General Services Administration in the United States, which focuses on national procurement policy for all federal agencies. And the importance of this is not only does it change the foods available and the healthfulness of those foods available to government employees, it begins to change the food supply completely, because the standards that we've instituted are ones which the contractors with the federal government must meet, and that in turn has the capacity for transforming the food supply, and I think is something that both the provinces and the federal government in Canada could begin to pursue if it's not in place already. Parenting and early care and education become particularly important. This is where that 30 calories a day in the 2 to 5-year-olds begins, and the 0 to 5-year-olds. And I think there's a lot of paradoxical information about parenting. For example, the more you urge a child to eat a food, the less likely they are to do so. And these types of strategies that I don't think are well understood by providers, but could be implemented not only in clinical settings, but in early care and education settings. This is what in the United States we call child care. The other area that is an important target is clinical care and management. In the United States, I think we have better developed public health strategies than we do clinical strategies. And those modest deficits that I showed you earlier that are going to return the BMI of children back to where they were in the 1970s, those are effective preventive strategies. They're also effective strategies to sustain weight loss after it occurs. But they're not effective strategies to achieve the caloric deficit that we have to achieve in obese individuals to get them to lose weight. That's going to require much better clinical initiatives than we have now, and much more innovative therapies that account for the high prevalence of obesity as well as those which achieve those deficits. And not only in the United States are we seeing an increase in the prevalence of severe obesity, we're also seeing an increase in the number of complications associated with severe obesity, as this slide indicates. Those have almost doubled over this about 15-year period, and I don't have more recent data. But since we can evaluate the costs of obesity in the United States, we know also that those severely obese individuals are also the cost drivers for obesity, which in the United States in 2007 amounted to about 10% of our national health care budget. You can see here, and these are self-reported data on BMI, that 8% of the obese population drives 40% of the costs. And yet we have not yet aligned our care delivery systems with the severity of obesity. These are individuals that are going to likely require more intensive case management and will not respond necessarily to primary care interventions the way individuals in the overweight or grade 1 category will do. And in order to begin to change the care delivery system, we need to think about how to change the educational system. There was a very good paper in Lancet several years ago by Julio Frank, which focused on characteristics for interprofessional education for the 21st century. And there were three major targets of those changes. One was we need to educate providers about how to work in teams. Secondly, we need to teach providers about how to link clinical and community efforts. And thirdly, we need to focus education on behavior change. We need to address bias in education because providers are subject to the same bias that the general culture is, and that impairs care. There are good data that suggest that that impairs medical care. We need innovative approaches that account for the prevalence of obesity, and in the development of those strategies, providers and our institutions need to be role models for the general population. In the United States, for example, a number of hospitals have partnered with the Partnership for Healthier America to sign on to standards for the development and delivery of healthful foods, labeling foods in cafeteria, marketing healthful foods, having healthy checkout lines in our cafeterias, having good standards for overall cafeteria and general menu offerings. Hospitals need to be the healthiest work site on the planet, and they're not. But they can lead this effort in much the same way that hospitals and providers led the initiatives around tobacco prevention and control. If we have time, I can expand a bit on that during the question and answer period. But I think that that changes in what we do in modeling these behaviors will have a profound effect on changing social norms around nutrition, physical activity, and obesity. We also know that providers who themselves are obese are less likely to counsel about obesity. Providers who themselves are inactive are less likely to counsel around physical activity. So the proverbial physician heal thyself or health professional heal thyself very much applies here. In addition, we need not only to change the medical care delivery system as shown on the right side of this slide, but we also need to change the environment to support those initiatives that we're trying to achieve within clinical settings. And family, in the case of children, and patient self-management needs to be at the center of this effort. Now, I don't have a lot of time to go through the remaining strategies here, but I did want to mention pizza because we focused a lot on sugar drinks, rightfully so, because they provide excess and useless calories in the diet and account for a fair number of calories. But pizza has been a neglected target, and these are data in the United States which show that that pizza ranks second in terms of the caloric contribution to the diets of children. Grain-based desserts like cookies, for example, tend to be a leading source of calories. The only group in whom sugar drinks exceed anything else as a source of calories is in 14 to 18-year-olds. But even in that group, pizza is second and supplies almost 9% of caloric intake. This needs to be a regular target and a difficult one because it's such a popular food with children and adolescents. About 20% of U.S. children or adolescents have pizza on a specific day of the study. About 50% of schools serve pizza on the specific day of the study. So this is an important but essential challenge. The final point here has to do with the importance of communication strategies. I think that what it's going to take to turn obesity around is a social movement, and I don't know that we have many of those elements yet in place. These are elements common to social movements, a shared and personalized perception of a threat. I'm not sure obesity constitutes that threat. I think this is where focus on co-benefits needs to be considered. So as I said earlier, what are the co-benefits of building a park or recreational facility? And that has its own value independent of its impact on obesity. We need to foster a grassroots commitment and develop social networks in much the same way that happened with tobacco, where innovative communities or institutions began to share information, and that accounted for the rapid diffusion of innovation. And finally, we need to think about how do we build this in a way that sustains action? Whose job is it at the governmental level and at the state and community or provincial and community level to focus on obesity? I don't think that we've sufficiently empowered our public health systems to do that. But in closing, I'd like to say that in the United States, I'm optimistic that I think we haven't turned the corner yet, but we are at the corner. And that that the engagement of communities and individuals in this effort gives me great hope that we're going to begin to see decreases in the prevalence of obesity. We still need to address disparities. We still need to consider these best investments. We still need to figure out what are the co-benefits of obesity prevention and control, and how do we build coalitions and alliances. But we are getting there. And I suspect that the same thing is true in Canada, and I look forward with great eagerness to seeing the changes that occur here. Thank you.
We'll take one or two quick questions. Definitely obesity is sans frontières, so I think everything you said, Bill, is equally applicable on this side of the border. It's very hard to see. Is there someone at any quick questions for Dr. Dietz? You need your blinders on.
Over here.
Okay.
Hey, good morning. Just a couple of comments. Can you speak on food deserts, high fructose corn syrup, subsidies for fruits and vegetables? Can you speak to the defeat of fat taxes in the U.S. by food lobbyists?
Do I have another half hour for this?
But and I also believe this conference is the shift. This conference, these professionals from all over Canada, the United States, and the globe are taking back messages that are about ending stigma and about creating new policies and new awareness. So I really believe that it's incumbent upon this group to ask questions and make the necessary changes. Thank you.
So the easiest way to respond to that question is that the food system from farm to fork is a very complicated system, and there are multiple interventions along those lines that include changes in food subsidies, as you mentioned, all the way out to changes in pricing driven perhaps by taxes. There's an initiative that's getting underway at the Institute of Medicine on the, and I would refer you to a workshop that we sponsored at the Institute of Medicine on the true costs of meat. That occurred about a year ago, and looked at the true costs, the externalities associated with meat, pork, chicken, and fish production. But there's now a consensus committee, which is a more elaborate process, that's going to look at that whole system of foods. I don't think it's going to come up necessarily with solutions, but it'll take the first step to developing a matrix that will begin to frame research and policy issues, and I think begin to inform not only the complexity of the system, but where the pressure points are within the system. Great.
Oh, can I ask one question? I'm right over here on your right at the back.
Oh, there you are.
I was just, thank you very much for that very precise and concise presentation on a very complex issue. I'm very interested to know if you would share with us your thoughts just on the extension of your comment about the obesity not being seen as a social movement. And I'm wondering if you would share with us your thoughts on the health at every size.
I think that's a critical strategy, and I didn't talk very much about that, but there's certain that we have to recognize that at this stage in our treatment that it's unlikely that we have strategies in place that are going to help most of the people who are obese lose weight. And so we have to be thinking about health at every size. And strategies like increased physical activity, increased fruit and vegetable intake, reduced sugar intake, all of those strategies, I think, would promote health at any size without necessarily inducing the level of weight loss that we need to achieve to reduce the comorbidities. Those strategies in and of themselves are likely to have an impact on the comorbidities.